Good. All right. For the next section of our presentation, we're going to go into hip fractures in the elderly. So first, as a little bit of review, we'll go over 4 of the most common types of hip fractures. So you have the subcapital neck fracture, which is just below the head of the femur. You have the transcervical neck fracture, which is right across that skinny part in the neck. Then you have the intertrochanteric, which the fracture splits the trochanters, and then the subtrochanteric, which is the fracture occurs just below the trochanters. And now you might be wondering, how does this happen in the geriatric population? And as you might guess, it is from just your common falls. There are obviously, other accidents that can happen, your higher velocity falls, your motor vehicle accidents, then your congenital issues and avascular necrosis and symptoms like that. But the most common is your low energy fall. So a few factors that increase the risk of hip fractures during the fall is that the point of impact is close proximity with the hip. So, when you start to fall, physics just kind of take over, and your hip ends up being the thing that hits the ground first, which can lead to a fracture in that area. Then there's also the inability of the soft tissues to absorb the impact. So as we've learned in our other classes throughout PT school, you have muscle wasting as an older individual, as well as the skin gets weaker, the bones get weaker, and so your body just can't take quite the same impact as it used to be able to. Next point kind of falls under that a little bit. The energy of the fall is greater than the strength of the femur. So ultimately, the body's tissues just aren't able to maintain against the force of gravity and the weight of your body coming down against the hard ground. And then ultimately, it is a failure of the protective responses of the body against the fall. So your body just isn't able to do what it needs to do to prevent itself from getting hurt, and thus you have a fracture. So now going into the treatment of hip fractures, I was able to find a CPG that was released by JOSPT in January of 2021, which I was super excited about. Very recent release of really great information on treating hip fractures. So we're going to go ahead and go on to the next slide and kind of look through this clinical practice guideline a little bit. So you see there, right there in the middle, physical impairment measures. They have letters by each thing that it's graded, A through F. So the things marked with the A's are what I paid the most attention to. So super important to gather knee extension strength as well as verbal rating scale for pain. And then you can see on the right there the physical performance measures. So calculating or finding gait speed, their timed up and go, their accumulated ambulation score is super important. And then you have 6-minute walk test and 5 times sit to stand or 30-second sit to stand there as well. And then moving down into the interventions, you have structured exercise, including progressive high intensity strength, balance, weight bearing, and functional mobility training. I love seeing that because these patients, they are just like a younger patient. They're just a little bit older, so they need that high intensity strength, balance, weight bearing activity to get their bodies back to where they need to be after that fracture is healed. And this can really be a great avenue for them to increase their physical fitness as well as return to their normal lives, which will in turn increase their quality of life. And then there's also moderate to significant evidence discussing multidisciplinary program. And so, that's been discussed throughout our program a lot of times, how important it is to involve all aspects of the rehab team and medical team in order to help our patients the most possible in the best possible way. And there in the bottom, interprofessional management, clinicians must assess risk factors for falls and contribute to interprofessional management of fall risk. So that's a great segue into my next point about fall prevention. This is huge for this population. Like we just said, it is the #1 cause for these hip fractures. And so the way we can prevent more hip fractures from occurring is to really educate these patients and try to catch them before it happens and enroll them in programs like we're familiar with Otago and Tai Chi and Matter of Balance. Involve them with the programs in the community to increase their strength, increase their balance, and really work on these aspects of their health that will help prevent a hip fracture from occurring. And then next, I'm going to move into hip replacement since we're on the hip. So I just want to talk about when is it time to get a hip replacement. I know it's not something obviously that's ideal. We as PTs would love to prevent that from happening as long as possible, but there are times when it's just inevitable that a hip replacement needs to happen. So I kind of listed a few there: end stage OA, unbearable pain, avascular necrosis of that hip. Well, I said increased quality of life, but to increase their quality of life, like they aren't able to participate in the activities that they want to, and PT can't really do anything for their pain anymore. So then I wanted to discuss the treatment and kind of modifications surrounding treatment for a total hip replacement in this population. So obviously with the hip replacement, you're going to have to follow all post-surgical protocols, which we've discussed in the past, so I won't go over those. And you're acutely going to increase strength, increase range of motion in the hip, in the leg, and obviously work them back into shape. But I was able to find a couple really interesting articles. One was done in the very acute phase, researched completing therapy 2 times a day versus 1 time a day, and they were able to reach their developmental milestones after surgery much faster. However, that really did not affect their length of stay very much. So I guess you can take that for what it's worth. And then I found another article, which was extremely interesting. And this was an interventional study. They kind of wrote in their conclusion, yeah, we need some more research on this one. But I thought I'd tell it to you guys. It really focused on reducing visits early after the total hip replacement for the first 12 weeks. And then they mentioned in the article specifically that during the 12 to 16 week time period, they would retrain higher level activities, and those are some of those are pictured there on the right, like with the slide board, golfing, more dynamic balance activities. And these all resulted in a positive effect in their functional outcomes as well as their biomechanics. And it didn't affect the intervention group's safety at all. So I think that's really interesting, and really I think we should think about this when working with our geriatric patients that have had their total hip replacements. So yeah, and these are the references. The CPG is I believe that top one or the second one. I think that would be a great resource to look at. It's got some awesome information in those articles. So on to the next section.